Conrado, you're muted. Conrado, you're muted.
Sorry, I start again very briefly. So I was, again, dear friends and colleagues, welcome to the second lesson of this module dedicated to hemodynamics. I am very pleased to emphasize once again that this year webinars are organized by WEMS and Hippocrates, but in a collaboration with the European Association of Perinatal Medicine. So I would like also to thank the today's speakers and Anup Katheria for his participation. And now I leave immediately the floor to the chairman of today, that is the president of IPM, Professor Iris De Campos. Please, Diogo.
Thank you very much, Professor Moretti. It's a great pleasure for me to be here representing the European Association of Perinatal Medicine, and for us to organize together with the UENPS and with the Hippocrates Foundation these joint webinars on best practice in neonatology and perinatology. We had a very interesting session yesterday, given more from the perspective of obstetricians, but also lots of perinatal concepts. And we're very much looking forward to hearing today's speaker. So without further ado, I'll pass it on to Ola Solstad, whom you all know, for the introduction of our speaker today. Thank you.
Thank you so much, Diego. And I also want to welcome all the participants. Today we have more than 2,000 registrations, which I think is fabulous. It's a great honor and a pleasure to introduce the speaker of today, Dr. Anup Katheria. He is the director of the Neonatal Research Institute at Sharp Mary Birch Hospital for Women and Newborns in San Diego. He is also an associated professor of pediatrics at University of California, San Diego. He is newly been appointed to the ILCOR committee, the recitation committee, and most of his work has been focused on delivery room interventions, including several multi-center, multinational trials in umbilical cord management, including cord milking and intact cord resuscitation in term and preterm infants. So with these words, Anup, it's great to see you here, and thank you for coming, and I leave the floor to you. Please, Anup.
Thank you so much, Ola, and thank you again.
Just one word to remind the participants that you can send in your questions in the QA box at the bottom of the screen.
Perfect. Thank you, and thank you again for inviting me to present. This is a really great group and very international. So some of this will obviously be slanted from a US American perspective, but I think what's great about cord management is it applies to all of our babies everywhere. And so looking forward for some of the discussion. Also, because there was a great speaker yesterday, Dr. Weeks, talking about the obstetrical management, and I know my colleague, Dr. Anderson, will be presenting tomorrow. I did cut down some of the slides because I think there is some overlap, and I do want to spend some time with questions. So apologize for some of the content that some people may want to discuss, where we can do that afterwards. No disclosures, but a lot of my research work will be presented, mostly funded by the NIH that's shown over here. And really this talk isn't about delayed cord clamping per se. It's about what are the challenges with doing delayed cord clamping. And I put up here pretty much most of the bodies that govern how we manage the cord. And so whether it's in the United States, ACOG that governs our obstetrical guidelines, ILCOR, which develops local neonatal resuscitation guidelines, EAPM in Europe, SOGC in Canada, or WHO in developing countries, they all have advocated for delayed cord clamping. That's not the point. The point are the underlying words, where really when it's a baby is needing resuscitation, or it's not feasible, or they need positive pressure ventilation, we don't have good definitive guidelines of what to do on those patients. And that's where we need further research, but we also need better evidence to show that really these babies can be managed and provided a placental transfusion. And that's where this talk is focused on, which is what do we do with these sort of 3 different modalities, whether it's resuscitating the baby at the bedside with the mother, taking a segment of the cord and milking it, or milking the cord several times. And I'll talk about these sort of 3 interventions over this talk. One thing that I did want to go into, I don't have too much time for physiology here, but really the concept of physiological base cord clamping, I think it's important we sort of discuss a little bit of the caveats of this term and how it's being used. This was really started based on some animal data by this fantastic group in Australia that had shown in preterm lambs that if you waited a period of time before resuscitating these lambs and while the cord was connected, or actually waited before ventilating the lambs after the cord is cut, you had this profound bradycardia compared to when you ventilated the lambs continually during delayed cord clamping. They had this nice stable heart rate and stable physiology. And they argued that this was the primary benefit of why we should keep human babies sort of with the cord intact and ventilating them continuously. One of the challenges, though, a more recent animal study had come out showing that if there was a shorter period of time after you cut the cord and then you started to ventilate them soon after, which is within 30 to 40 seconds after birth, compared to ventilating them continuously, there wasn't this similar amount of bradycardia or difference. In fact, if anything, the babies or the preterm lambs that had their cords clamped right away actually had higher heart rates. And I'll show how this sort of differs in what we see in the animal model compared to in human trials when we're looking at human hemodynamics, and really arguing that there might be differences in terms of the physiology and how we explain the benefits of delayed cord clamping or even ventilation with an intact cord. Just one sort of important thing when you're looking at animal models is to understand the differences between animals and humans. And so when you look at an animal placenta, it's really multiple little placentas or cotyledons that come together and fuse to a short umbilical cord that has no Wharton's jelly, has 2 veins and 2 arteries. So this is a very different model than what we see in human babies. And in fact, when we think about the observations for human infants, the lamb model is a fantastic model for physiology and lung changes and studying a number of these things that happen at birth. But the key, most important thing to remember is there is no placental transfusion in lambs. When you look at sort of a taker, this is from one of the animal studies from Australia, the net flow from the umbilical vein and umbilical artery from ventilating even to when the cord is clamped, there's really no net difference. And so the amount of blood going into the lamb and versus coming out is equal. And that's not what happens in humans. And the things that happen to these lambs don't happen in humans as well in terms of draining lung fluid, instrumenting and intubating them. But they do have some important points for physiology. And so we have to decide, at least for me as a clinical trialist, what do I take from here to adapt in terms of understanding these changes in humans and being able to apply terms such as physiological base cord clamping to a human baby that has sort of different physiology. Now, that being said, there are some really good human physiology studies. So this is one by some of the same authors from the group in Australia collaborating with the group in Leiden and looking at changes in the ductus venosus, right? So when the blood is coming through the umbilical vein and going into the baby, it's going to cross the ductus venosus and enter the right atrium. And so one of the things they noticed is while doing ultrasounds of the heart during delayed cord clamping and looking at the ductus venosus and the hepatic vein, they found that the majority of the anterograde blood flow, the blood going into the heart, was during inspiration. So essentially, as these babies take these breaths, blood is being pulled in from the placenta towards the heart. And that's important because breathing, as we know, is a very important part of how placental transfusion is augmented in these infants. And on top of that, it's important to know what are these other changes that are happening in terms of cardiac physiology. The biggest thing that I'll highlight is that cardiac function is actually not so much stable, but it's actually improving minute to minute. These are just a few studies by the group in Ireland. We did some work in San Diego, as well as the group in Egypt, looking at improvements in cardiac output and stroke volume every minute the baby was remained attached to the cord. And so this increase in cardiac output by increasing the amount of blood flow going into the baby's heart sort of explains why you would see these changes over the first few minutes, or even in the study out of Egypt, even up to 24 hours of life. Now, when we take this sort of physiology and try to understand that in babies that need resuscitation, there are 4 trials that, at least that I know of right now, many of them that are continuing on, and you'll hear a lot of good ones tomorrow from Dr. Anderson, much larger studies that he's conducting himself. But these sort of 4, relatively smallish studies in the sort of hundreds and 200 that have been conducted were all in high-risk babies. Either they were deemed to need resuscitation or they were at high risk of resuscitation, and they received anywhere from 3 to 5 minutes of delayed cord clamping because they could receive respiratory support. And what they showed was in these studies that the APGAR scores were better, their oxygen saturations were better, but interestingly, the heart rates were lower in those babies that received intact cord resuscitation, because you're really now improving the amount of blood flow going into these infants. The challenge, and this is where we need future research, and the reason we haven't adopted this, is these studies didn't really show hard improvements in clinical outcomes. And this gets into, well, whether or not we're picking the right babies that need intact cord resuscitation, or will they benefit from just delayed cord clamping alone? So I've shown this video many times in previous talks. This is a baby that was just randomized to receive CPAP during delayed cord clamping. And you can see this baby's actually quite vigorous, moving around. And this baby, you can see this hand is moving sort of away. This baby's quite active, but still receiving support. This also highlights the sort of challenges as we're trying to adopt something like intact cord resuscitation into an operating room where you have 2 obstetricians, a scrub tech, and you're all trying to fit this into one little space. And this is something that we're trying to get our heads around for trying to develop this. With that being said, particularly in Europe, which I think is the majority of this audience, there's been a boom in having equipment that allows you to do intact cord resuscitation. And again, I have no financial disclosures with any of these companies, but there's a Concord trolley that some of you may know that's being used in many centers. There's a LifeStart trolley. And then even in North America, where I am, groups are developing their own carts to be able to use this. But you could just see the number of countries that have adopted this and implementing birth trolleys just over the past 5 years. And the European Resuscitation Council has even gone further in their guidelines to say that when you can provide thermal care and resuscitation safely with the cord intact, you can actually begin these interventions during delayed cord clamping. And I think this has really opened the door for many people to start implementing this. What is interesting is, and I'm not arguing that we shouldn't be doing this, but there is no good evidence saying that this is beneficial in terms of RCT data. And you might say, no, that's not true. I know there's studies that have. Well, if you look at every randomized controlled trial that's been published so far, and these are the authors and the number of studies and the primary outcomes over here on the right. In bold here, I put the durations of how long they went with the duration of delayed cord clamping, and the ends in these studies are not large scale trials, but none of them really hit their primary outcome, whether it's a physiological marker or a clinical outcome. And even more recently, we have some clinical trials. And again, I know many of these have not been published, so I won't give you all the intimate details, but they've all looked at ventilating the cord, again, ventilating the baby during delayed cord clamping anywhere from 2 to 7 minutes. And these are large trials, one out of US, Italy, and out of Europe and Australia, but they did not show a difference in their primary outcome. And I think this is where we need to figure this out. What is the next step in terms of improving how these babies do to improve how intact cord resuscitation is being done, or what's different in their physiology? When we look at the study interventions that have been done in preterm infants, it's important to know that some of the adherence is always a challenge. When you start off from some of the early trials by Judith Mercer, where the compliance rate was quite high, over 85%, And as we've gone longer in the duration, we've had more challenges getting the team to be able to keep the cord intact longer. So while the idea of keeping the baby intact until the baby's physiologically transitioned and has saturations of 90, 95% and is breathing and ready to go to the NICU, that sounds great. But what is the reality of the adherence of how well we'll be able to do that? And I think that's something we need to figure out, because these are in research studies. This is not even in clinical practice. And again, I'm maybe only speaking from my own country. It would be very hard for US providers to do a longer duration such as this in the OR, in the operative room, where there's concerns about maternal bleeding and so on and so forth. Some of the things I'll just highlight as we're going through this talk is for future directions. How do we improve these things? Well, my first study looked at comparing CPAP alone, and we used room air because we really felt at that point in time that was the safest sort of mode. And then we compared that to just drying and stimulating the babies alone. And what this trial did not show any benefit of providing CPAP. As I showed you in those slides earlier, that the outcome was no different. But we looked at the blue line versus the red line here over time, they were virtually identical, which is when you started support on these babies, there was no difference for when you compared to just stimulating them. And at 20 seconds, you had 40 to 50% of these babies breathing. By 40 seconds, you can see here, it was closer to 70%. And it's until 60 seconds that about 90% of these babies were breathing. So it shows that, in fact, there is no difference in terms of whether you provide CPAP or not. But it may also show that it can be done and it's not actually harming the infant as well. Now, when the idea we had of how we could improve this came actually from one of my studies that showed harm with cord milking. And I'll talk about this in the cord milking section, that we compared cord milking compared to delayed cord clamping alone. We didn't give them CPAP. We just had 60 seconds of delay in these extremely preterm infants. And what we saw now is that the babies who received cord milking, as shown in the solid line up here, compared to this dotted line, which was the delayed cord clamping group, actually had better oxygen saturations in the first 10 minutes of life. And in fact, when you look at this 80% marker, and I'll highlight why this is important, that by 5 minutes, about 2/3 of these babies that received delayed cord clamping actually had lower oxygen saturations. And this is important because of a number of studies that have been done, and you know, we have Ola Soksagt here and others that have really pioneered the idea that if we don't improve oxygenation by 5 minutes of life in these babies, they're more likely to have very bad outcomes. And this has been shown time and time again that death and severe IVH are increased quite a bit if you don't oxygenate well. And so what are some of the strategies that we can use? Well, one recently presented meta-analysis that was at JENS last year in Europe showed that if you started at higher oxygen in babies, when you looked at all the different studies that had been done, putting them together as an individual patient meta-analyses, that those studies that started at high oxygen, which is pretty much at 100%, actually had the lowest mortality in the hospital compared to any of the other interventions, where most of us are starting at 30%. There was actually no benefit. These studies still need to have more patients, and they still need to really answer this question more definitively. But it makes sense that you might need to give them more oxygen to be able to improve the outcomes of these infants. Now, why could this be important for something like delayed cord clamping? Well, one of the challenges with intact cord resuscitation is getting these babies to breathe. And there's been some great work by, again, the group in Europe looking at glottic closure and opening. In fact, surprisingly, the majority of time when these babies are actually first born, they have a closed glottis. So you're trying to ventilate them and none of this air is going in. Studies and others that demonstrated that you couldn't get the airway open until 30 to 60 seconds of life, which for many of us, that's the period that delayed cord clamping is even occurring. So no air is even going into these infants. And we know that hypoxia and cold stress, cold is an important negative thing that we have to deal with delayed cord clamping, because our operating rooms are very cold and we're constantly trying to warm these poor babies up and putting them in little plastic bags and thermal mattresses, but that alone allows them to clamp down as well. And so the only recent study that's looked at 100%, because this is still very controversial, is the group in Leiden randomized babies to 100% versus 30% after the cord was clamped, and sort of looked at their oxygenation and some of their sort of downstream outcomes. And what they showed here was that if you titrate oxygen fairly quickly, the amount of oxygen exposure was no different, but they had better oxygen saturations in the first 10 minutes of life. You could see here by the light blue line that the saturations were much higher. You can say, yeah, that makes sense. If I start higher, their oxygenation should be better. But at the same time, when you look at how these babies are breathing while they're receiving this increased amount of oxygen, their minute volume, tidal volume, respiratory rates, et cetera, were all better during this period of higher oxygen. They also looked at oxidative stress markers at birth and at 24 hours, and they show that these weren't different as well. And so part of this would say, well, maybe giving some more oxygen to these babies might even augment delayed cord clamping, or at least this period of providing support. The other important meta-analysis, and you'll probably hear about this again a little bit tomorrow from Ola, is the Lena Sadler's meta-analysis looking at longer delays of cord clamping compared to clamping early or even cord milking. And what she showed in her meta-analysis was that the babies that received 2 minutes of delayed cord clamping or longer had the lowest probability of death before discharge, and that was comparing a number of these trials. Again, there were only a few trials that actually went out to this duration, and the gestational ages are quite wide, and it doesn't get into whether or not to provide support or not on the cord, although some of these studies actually did, and that's sort of where we need more data to be able to understand this. But from these two meta-analyses, it looks like extending the duration and providing a little more oxygen are probably two good approaches that could augment how intact cord resuscitation is happening. And so part of this was we did some animal data collaborating with Satya Lakshrima at UC Davis, and we were able to show in lambs that if you gave them 100% oxygen after the cord was clamped, they had huge surges in PaO2. But if you gave a short duration of 100% oxygen while the cord is intact, it actually made no difference compared to just giving them 30% after the cord is clamped. But when you looked at their oxygen saturations in these preterm lambs, they followed the sort of middle of the road. They didn't overshoot, but they also weren't hypoxic, as you would expect in babies that start off with lower oxygen. And part of the rationale with this is that in a human baby, we're not intubating them, so they're not getting all of this oxygen. We're actually having to give it via a face mask. And again, the challenge with these babies is getting them to breathe and have an open glottis. Well, you could probably overcome some of that hypoxia glottic closure by giving them this brief exposure of 100% oxygen. Now that sounds like it'd be very terrible for their lungs and their body, but you're actually streaming in deoxygenated blood from the placenta continuously. So the amount of oxygen that gets into their systemic circulation to the brain and mitochondria could potentially be much lower. And so again, this is all still theoretical, but we need to be able to study what we see in the lab model in humans. And so we started to conduct the DOXY pilot trial with my mentor, Neil Feiner, and Satya Lakshrima and Robin Stein, who are our world's experts on pulmonary hypertension. And we're comparing 100% to 30% oxygen during delayed cord clamping to reduce the incidence of hypoxia, which is a saturation of less than 80% by 5 minutes of life. And we're going to, or we're already doing cardiac ultrasounds, NIRS monitoring, and most importantly, I have the two world's experts on hyperoxic lung-induced injury and free radical damage, Max Vento and Oleg Sogstad, that are monitoring our babies to look for oxidative stress. And also we're going to be we are checking cord blood levels and 1 hour baby blood levels for oxidative stress markers that Dr. Vento and his lab are helping us understand to see whether or not can you give 100% oxygen non-invasively for a minute, and does that improve outcomes without causing harm? And that's going to be the big part. And after this study, we're actually planning this summer to, if these results are significant, to do a multi-center trial across the United States as part of the Neonatal Research Network in over 1,000 babies. And again, my challenge, this talk isn't about this, but I could spend another hour talking about the challenges of intact cord resuscitation, how hard it is to do. But we recently started filming simulation videos where we're now using things like the NeoBeat to practice on babies, looking at scenarios with short cord, vaginal birth, and even hemorrhage situations to be able to teach centers how to do this if we're going to conduct a large multi-center study. So this first half of my talk, I think I'm about 20 minutes in, really highlights that yes, resuscitation in an intact cord has some physiological benefits. I've showed you about APGARs, shown you these heart rate differences, but I think the key take-home point, and we talk about this in the question and answer session, the studies have not shown superiority over delayed cord clamping alone. If you're a center that's struggling to do 60 seconds of delayed cord clamping, I would focus on stimulation. I would not focus on getting a fancy trolley to improve your rates. You need to work with your obstetricians to allow these babies some time to transition on the cord. And really, we need trials. We need to fine-tune how to do resuscitation with an intact cord, giving the babies maybe some time to transition, then putting a mask on their faces. These are things that I'm constantly in dialogue with others about, and how to really optimize the way we use this before it becomes standard of care for these infants. And so with that, I wanted to talk a little bit about the second half of my talk, which is umbilical cord milking, and what are sort of the situations where we can or should not be sort of doing this intervention. So part of what we've tried to do over the last 10 years is really tease out the literature, because cord milking has been used very interchangeably with intact and cut. So you'll probably see more and more studies that will try to insert this word intact cord milking, which is this photo on the left, compared to what you see on this video on the right, which is a baby who's had a long segment of their umbilical cord cut, and now they move the baby over to a warmer, untwist the cord, and milk this cord one time. And again, I'm stressing this because it's so important you understand how these procedures are done and how the terms are used, because I can't tell you the number of times I reviewed a paper where they tried to milk this type of cord 3 times, which is very different than doing this type of cord. Now, umbilical cord milking has had some very negative connotations on all babies because of the concern of these huge hemodynamic shifts when you're milking the cord, where in this preterm lamb trial, every time the cord was milked, there were these fluctuations in carotid artery blood flow compared to delayed cord clamping alone. Well, I just finished telling you at the beginning of this talk that lambs do not get a placental transfusion. So if you push blood into a lamb, what will happen is the blood will come right back out. And that's unfortunately not what happens in a human baby. And sure enough, more recently, 2 new animal studies, both by a group in Buffalo and another one by Australia, said, well, if the lamb actually is able to breathe, actually their fluctuations go away. And so when you compare this top panel that showed a fluctuation without ventilation compared to with, there's no different, big swings in blood flow. And similarly, this panel on the right that shows milking after ventilation compared to before, so there's a huge dampening. So it's really the lack of ventilation, or a lamb who's under anesthesia where you're pushing blood in and the blood comes right back out, compared to a human baby that actually can begin to initiate ventilation. And we've seen this even in our own studies where babies who receive cord milking are actually starting to breathe more. And as I'll show you later, may actually need less resuscitation. But what I do think is important is milking is a very effective method of providing a lot of blood to a baby. So our first trial that was now it's almost 10 years ago, compared milking to delayed cord clamping in preterm babies, and showed that here in this dotted line compared to the solid line, they had better blood pressure and they had better measures of systemic blood flow. So we thought, okay, this is great. We're now improving blood flow and blood pressure in many babies who can be hypotensive and have low blood flow. And so let's do a multi-center trial to test this. Well, the reason you do multi-center trials is you get a lot more babies than just 150 or so that we had in this study. And what we found, though, unfortunately, or fortunately, depending how you look at it, is that there was harm. If you milk babies' cords, it's particularly between 23 and 27 weeks, and I'll explain why this gestational age is important, because I know it creates some confusion, but it's also important physiologically to understand that the babies who had almost a 4-fold increase in severe IVH were babies that received cord milking in that 23 to 27 week gestation. You could see the p-value and the interaction effect. Similarly, the majority of babies that had severe IVH were babies born by vaginal birth, almost a 6-fold increase in severe IVH. The sectioned babies did not see this dramatic difference. And I think, again, when we look at how people are even today doing cord milking in extremely preterm babies, you have to ask why they're not seeing the same sort of concerns that many people have said about cord milking. Well, the Japanese are a great example. This is a statement from their resuscitation guidelines. And in Japan, they intentionally deliver babies via cesarean section. And actually, I know they do this in some European countries, like in Cologne, Germany, for instance. Extremely preterm babies, it's thought that, well, let's do an intentional C-section delivery, deliver them and call, etc., because it protects the baby as they're being delivered. Now, that could be debated, but really what they're doing is they're doing cord milking in these cesarean section deliveries. They're actually taking the baby over with a long segment of the cord, like cut cord milking, and milking them. And they're saying, well, we don't see any severe IVH in this population, but it's probably because how it's done in the mode of delivery. I'll sort of explain this a little bit further with this nice cartoon that Satyan did for me, which is if you milk the cord in an intact placenta, right? I said that that placenta that has a uterus contracting around it is going to really facilitate a placental transfusion, particularly at vaginal birth. And now you're milking the cord in the presence of these contractions. As you're milking the cord, you're milking both the artery and the vein and giving a lot of blood volume to this extremely preterm baby. On the umbilical venous side, if these extremely preterm babies are not breathing well or they have a lot of RDS, which is true at the lower gestations, they're going to have higher pulmonary vascular resistance, higher RV pressures. So the blood will go across the foramen and into the left side of the heart, increasing left-sided preload. Similarly, on the other side, if you're milking the umbilical artery, you're also increasing the amount of blood flow into the descending aorta. As you increase these two things together, you increase the amount of blood flow going into the carotid and other vessels. In the presence of chorioamnitis, we have a lot of inflammation. That's going to make the germinal matrix even more fragile and more prone to bleed, and therefore you'll see more severe IVH. And so even in our study that was published a few years ago, when we took chorioamnitis away, we didn't see any more severe IVH with cord milking. When we took vaginal delivery away, we didn't see this difference in severe IVH. But you can't make a recommendation for these specific instances. It's much cleaner to say, just don't do it if these babies are small, because that's something that you could uniformly adopt. So it's hard to get the messaging across. It's important to understand the physiology when you compare different populations and groups that are seeing this. Another way to highlight how effective cord milking is with providing additional blood volume is by some of the early work by Judith Mercer, who looked at the amount of blood left over. So this is not the blood going into the baby, but what blood is left over in the placenta, or known as placental residual blood volume. And she's been pushing me to do this in the extremely preterm babies, which is more challenging, but you can see how accurately you can define the amount of blood differences that are in these different groups. So when you look at immediate cord clamping, over here on the left, that's where the majority of the blood will be left over. If you get down to 2 minutes, you'll only have about 25 cc's per kilo left. By the time you get to 5 minutes, there's very little blood left. And many would argue that we really need to go much longer to get all that blood into these babies. Cord milking falls somewhere between a 2 to 5 minute delay, which many of us don't do in our extremely preterm babies anyway. But this is a lot of additional blood for these infants. So there may be situations where this could help, but for the majority of the time, it might be a lot more than these babies need. And I think that's where we need to be careful with cord milking in extremely preterm infants. When you compare that to immediate cord clamping, it's important to note that all these trials today did not show any increase in severe IVH. So there's still harm with immediate cord clamping in preterm babies that really isn't any worse or better than milking in these infants. So you could argue there may be situations where it might be important to milk a baby that's preterm, for instance, an abruption or where they need this additional blood volume. But I think, again, trying to look at these different gestational ages might be helpful. Now, when you move above 27 weeks into 28 weeks and up, why do we think that's any better or any safer to milk those babies' cords? Well, if you think about it, again, physiologically, what happens when you milk a cord at above 28 weeks? Well, these babies are more likely now to have initiated spontaneous breathing. They're less likely to have a lot of RDS, right? We don't intubate a lot of babies above 28 weeks and give surfactant, at least compared to the smaller babies. And even if they get this additional blood, into their brain, etc., they're less likely to have severe IVH. We don't see that very often in these babies, or even low-grade IVHs are less common. But again, this was theoretical, so we had to study this. And so we continued to enroll babies above 28 weeks and enrolled up to 1,000 babies in these 20 centers shown down here. Many of them that were also in Europe and Canada that participated. And we first had looked at IVH, and we also want to look at 2-year outcomes that we're still finishing up that data over the next year or so before we finish that trial. And what we showed was, and then we published this in Pediatrics last year, is that there was really no differences in severe IVH between these groups. No differences in hemoglobin, but again, you can see the trend was, like as you'd expect, benefit more in the cesarean section babies, less severe IVH as you would expect in the vaginal delivery babies. But again, these are lower numbers, but it goes back to what we talked about originally, which is the physiology is different by these mode of deliveries. Placental transfusion would be different. And so really, when you look at these event rates, even overall IVH, there's no increased risk of milking cords above 28 weeks. And you can see here in the forest plot too, these confidence intervals really around 1%. Again, for the paper, we couldn't declare true non-inferiority because our margin was very strict at 1%. But I think for the most part, this trial does not probably need to be replicated. It's probably pretty clear that we're not seeing any increased IVH risk. Now, you could argue, let's wait for the developmental outcomes, and that's totally fine. We'll have those data by next year. And then just for the last part of this talk, I just wanted to move even to the more mature babies, which are the near-term babies, 35 weeks and up. We did do this cluster crossover trial to try to really answer the questions, what do you do in babies you can't do delayed cord clamping? Now, you'll hear from Ola tomorrow. Well, you could ventilate them with an intact cord. Again, that may not be something we can all do all the time. So if you have a baby who's floppy, not breathing, you really only have 2 choices. You can either clamp the cord right away, or you could milk the cord. What's better, what's safer, etc. And how do these outcomes sort of fit between NICU admissions, other secondary outcomes, and neurological outcomes at 2 years of age. Now, the trial, just to sort of explain it more simply, we did this over 2 years where every center was randomized for 1 year to do one intervention, and then they would cross over for the second year and do the opposite intervention. If you were vigorous by 15 seconds or so, we wanted to give our obstetricians some time to assess the babies. The babies who were starting to breathe, well, great, then just do delayed cord clamping, and they're not in the trial. If they're not breathing, or they still look floppy, and they're not initiating a good transition, they get randomized. And that's where we included them in the study. These are the exclusion criteria over here on the right, kind of what you see in most cord clamping trials, so on and so forth. I'm not going to spend a lot of time with all of the data. Our primary outcome was looking at NICU admission. So while it looked lower when you adjusted by center, it was no longer significant. But we did see reductions in the need for resuscitation in the delivery room, higher hemoglobins, less moderate to severe HIE, less need for therapeutic hypothermia, higher bilirubins, and a better 1-minute APGAR score, all with those babies that received cord milking at birth. So as part of that, we saw that short-term outcomes are probably better with cord milking. One of the concerns, and you might hear this again tomorrow too, is, well, what about giving all this blood to these babies? Is it harmful to the heart in the transition? And so for the most part, when we looked at 200 babies that we did cardiac echoes on, we saw improvements in measures of systemic blood flow, like left and right ventricular output, SVC flow. We showed that they need less oxygen in the delivery room. The only thing that you could say could have been negative as far as harm was there was more stretch in that right ventricle. So the TAPSE was actually lower with cord milking compared to early cord clamping. But every other measure showed, in fact, you were probably pumping more blood out of the heart and improving transition in these babies with milking or not. Now, I will be presenting our 2-year outcomes at the PASS meeting, but specifically, I know Ola won't be there, so I had to include these slides here for sharing. The study was looking at ages and stages questionnaire. This has been some really good work that Ola Anderson's done with looking at ASQs in babies with delayed cord clamping, and it sort of made sense that a lot of these families won't be able to be assessed. Can we assess how they're doing developmentally? So it's a validated questionnaire that looks at 5 domains. We also did the MCHAT, which is another social behavioral measure that actually is more predictive of abnormal later childhood problems, and not just autism, which it was designed for. And so we administer these screening questionnaires across our MINB cohort, and really reassess them every 6 months out to 2 years of age. And so the primary outcome was just looking at NICU admission, and then we asked families if they would participate in ongoing data collection and being in the follow-up study. So 1,200 consented to be in the follow-up study. Of the 1,200, 970 were able to be assessed for at least the ASQ. A slightly smaller number were for the MCHAT. And what we saw here was really the groups were similar across the board. When we adjusted for these different demographics, they were not different. Even C-section was similar when you adjusted for it. But at the end of the day, these groups were overall balanced. When we looked at the ASQ domains, and instead of just showing you the raw number, I show you the spread and sort of the skew here. There were really no differences across any of the domains when you compared the two groups, whether it's communication all the way down to personal social. But when you looked at the babies with abnormal scores, you can see anywhere from about 5 to 10% of these babies in both groups had some abnormal scores, but overall they were similar between the two groups, no differences across the board. And similarly with the MCHAT scores as well, again, high scores being bad, these scores were also similar as well. Now, most of the time you want to see a benefit. I wish we had showed improvements in some of these scores, but overall they were similar. Now, the question is, if you see these short-term benefits in terms of cardiac function that I showed you earlier, as well as these short-term outcomes, and you're not seeing any adverse effects with cord milking in close to 1,000 babies, the question is whether this should be adopted for these near-term babies. When you look at the guidelines for vigorous babies, as here shown on the left panel, you can see they're always geared for term and preterm infants. There's nothing for non-vigorous babies until only recently. Well, and I take that back. The Europeans have, there's the UK Resuscitation Council that allowed you to do it, but very few groups were actually doing milking in any babies above 28 weeks. Now, in the US, we've recently said that babies 35 to 42 weeks can receive cord milking, and this is before our 2-year outcomes that have been sort of published. So the hope is people can use this as a tool for a specific group that cannot get delayed cord clamping or cannot get intact cord resuscitation. And so the hope is we will be able to adopt that soon. And hopefully our obstetrical colleagues, at least in America and hopefully across Europe and other continents, can adopt this as well. What about cut cord milking? Well, I'll just quickly say that none of the studies have shown any benefit over intact cord milking. So the idea is that, well, if you're going to milk the cord once, if you milked it a few more times, you actually could get better blood into the infant. So if that's your goal, it sort of makes sense to do it while the cord is still intact. But there are people still trying to study this and sort of compare it between these other groups. Just very briefly, I'll show you 2 studies, one out of India that showed no differences in their outcomes other than higher hemoglobins with cut cord milking compared to not milking babies that were preterm that needed resuscitation. And then another study out of Hungary that showed higher hemoglobins with intact cord milking compared to cut cord milking. We still need more data, I think, before people start using cut cord milking. There's a very nice study out of China that's looking at over 1,600 babies, comparing intact, cut, and delayed cord clamping to look at severe IVH. And then 2 trials that I'm a part of here in the US and in India, looking at babies with delayed cord clamping and congenital heart disease. And then another, which I think will probably really highlight if there is benefit with cord milking, is a study out of India where HIE is 10-fold higher. And Zubaira Guy at Jefferson is leading this to look at over 3,400 babies that are depressed at birth and not breathing. Do you reduce HIE? And we know HIE is very controversial in India with the cooling trials not showing benefit, or at least some of them. Do we have another method that we could use at this point? So I'm out of time. So just as this is a quick take-home slide, that What are groups that you can do milking versus delayed cord clamping? Really avoiding the middle here as much as we can. I mean, that is our goal. When people talk about, well, I should really be doing delayed cord clamping, and the answer is absolutely. We need to avoid immediate cord clamping as in many situations as we can. Hopefully the future would be more babies that can receive intact cord resuscitation, but I don't think we're quite there yet. I know you'll hear more about that tomorrow. So thank you all to our collaborators, and I will end now for questions. Thank you.
Well, thank you so much, Anup. This was fabulous, very, very nice, very interesting. We have approximately 15 minutes for questions and comments, and I will ask, and we have received some very interesting questions in the box. And for those who want to ask questions, please go ahead and send in your questions. I would like to ask Ola Andersson, who's here, would you like to start giving a comment or a question?
Well, absolutely. Thank you, Anup, for this very, very fact-full presentation. You really put in a lot of data in these few minutes, and I think that you really showed that for the moment the new data from the MINVI trial has opened up the possibility of thinking of cord milking as the by now perhaps the most obvious way of helping babies that are late preterm and term in the need of resuscitation, as you say, and which I will talk a little bit more about tomorrow, on that the proof or the evidence from the trials that have tried to give resuscitation or stabilization efforts hasn't been showing so much positive data. So I think that you really described this in a very comprehensive way today. So thank you for that. And I actually don't have so many questions or comments. I just think you really did a very good work of summarizing what we know today. So thank you for that.
Well, I know we're thanking each other, but I really think your early work and trying to do longer term outcomes has really paved the way that we're not going to be able to convince people to do placental transfusion studies without follow-up data. So when you did those original trials, looking at 12 months and then out to 4, that's what I wish we could do. And I can't convince people to do the 4-year data, because I think that would be even more powerful. But if you remember, most people, at least in America, were not going to advocate for delayed cord clamping for term babies until they saw that data, despite hundreds of trials showing short-term benefit with delayed cord clamping. But until we saw that publication, people would not adopt these things. So thank you to you and your work of doing that. And I encourage others that are listening. I see so many papers of, yes, we improved hemoglobin, we improved iron. That's great. But until we show that these babies neurologically can do better, we're not going to change the guidelines. And if that's your goal, I think we need that. And I know, I'm sure in the SAVE trial, you guys will follow these children as well. But I think to convince people, that's what we need. And I applaud you for doing that early work for the rest of us to follow.
I have a question to the two of you gentlemen. And Anup, we discussed it a little bit before we went on the air. And actually the 2021 update from ILCOR on newborn resuscitation, they have summarized the effect of delayed cord clamping in term babies. And what they wrote was that there is an increased risk of hyperbilirubinemia. So I wonder, and I know that we had discussed this before, and Ola, you have looked at this, but I wonder, is this a concern for instance, low and middle income countries where you don't have access to phototherapy as much as in high income countries?
Although you want to answer that, you've done so much work on this topic.
Yeah, well, I must say that all the data we have, I think it's almost 2,000 babies in Sweden and 1,000 babies in Nepal. we haven't seen in term infants that there is any higher risk for hyperbilirubinemia. So we have, I think we have, I have quite great confidence. But what has been shown is in preterms and also in children with cardiac heart disease, congenital heart disease, there might be a higher risk of hyperbilirubinemia. And of course, especially the preterms, you will follow the bilirubin and will give them the phototherapy. So I think we have to divide the thinking about hyperbilirubinemia between the rather term well-being and the ones that are have a problem with their liver metabolism.
So is it a concern in low-income countries where you don't have access to phototherapy to practice delayed cord clamping?
Not for vigorous term infants. We haven't seen that.
Okay. So then we jump on to the questions. And the first one is actually from Norway, I think, Elizabeth Sæther. Why are we still talking about time-based cord clamping? How can we, as bystanders, know what timing that is right for the individual baby without considering the individual baby's transition efforts? The baby will not only receive a placenta to baby transfusion, he will also need to send some blood back. Any comments? Yesterday we discussed why because the speaker yesterday, Professor Weeks, he said we should wait 2 minutes, and most of the recommendations you showed in the beginning of your lecture, Anup, see that recommendations are 1 minute or more.
Right. I mean,
so why 2 minutes? Why not? Yeah.
Well, I think, yeah, and I know, Ola, you've been advocating for 3. I think a couple things. One is, you know, for the healthy term baby, I think you need to go as long as that baby needs to go to transition. I think what we've been focusing on, Elizabeth, and this is the challenge, is the extremely preterm babies. We're dealing with multiple things. I would say, yeah, you could do a longer let the baby dictate, but that's where I get into the challenges with physiological based clamping, is that what does that look like in a human infant? And now we have trials that are not showing necessarily any benefit. In fact, some of these studies are even showing more hypothermia and other concerns. So there is a balance, and there is a challenge of resuscitating an extremely preterm baby, providing CPAP and support in a adequate way where you have the ability to monitor and see how this infant is doing. Very different, though, than the term baby delivered by a midwife that can have lots of time to transition with the mother. And I'm all for not having a time for that. But I do think we need to decide when to move certain things over to allow these babies to be able to adapt. And I think that's what we'll figure out with these intact cord resuscitation studies. And I think you have to start somewhere, which is, to do a study, you need some sort of time window. You can't just say, well, I look at the baby, now the baby looks like they've transitioned, so that's going to be my outcome. It has to be something a little more concrete. And then centers can adapt it the way you have, to just sort of look at the infant and allow them to sort of transition that way.
I know that in Sweden, yeah, sorry.
Go ahead.
I know that in Sweden, Ola, some of the midwives, they wait 6 minutes or even more.
Yeah, well, it's not some; it's the median time today. So more than half of the midwives. And my comment to both Anup and Elizabeth is that I think that Elizabeth perhaps thinks it's what is the measurement? What? And I saw Simon Pratesi had that in the question here also. How do we decide what baby that needs resuscitation? We have been looking at the heart rate, we've been looking at the oxygen saturation, but and we have the APGAR. We have different measures, and we even did an interview study on midwives, asking them how they decide when to call the neonatologist or the children. So I think there might be, as Anup talks about, there is perhaps we need to think, when we have an intact cord, we need to reassess a little bit, when do the baby really need measures, and what kind of measures do they need? But it's more of a question than any answer.
Yeah, okay. I don't know if Elizabeth, you are satisfied with this, but it was an interesting comment, a question, I think. We have to move on, and the next question is from Kathleen in Belgium, and she asks about implementation of intact cord resuscitation in level 1 or 2 units. What do you think about that?
Yeah, I would ask her back, are you even able to achieve delayed cord clamping at some duration with just stimulating those babies? And I would say that would be my main focus. And if you're really trying to go longer, like let's say, okay, I want to support these babies on the cord for 2-3 minutes, then there's an advantage of providing some support and not just doing stimulate. At least this is my opinion, that those might be babies that still need CPAP or some oxygen or some support. But if you can't even get to 60 seconds and you're looking at getting intact cord resuscitation, I think you have a problem, and you should focus on working with your obstetrical and midwife colleagues to really get them to help that baby transition in that first minute.
Okay, and then we have another question. We are using Life Start device, and we realize that preterm babies have very low temperature at admission. How do you manage the temperature problem?
Yes, and so you know, I hate to say this, but the Life Start trolley does not do a good job of warming these babies. And so what we've done is added a chemical warming mattress on top of the trolley to provide more heat. And we put the baby in like a plastic bag thing to help sort of avoid insensible losses. And we check a temperature on all of our babies at 5 minutes as part of just, it's always been our quality assurance issues, and we have not seen issues with that. When I first started doing delayed cord clamping trials like 15 years ago, we had hypothermia, and it was a problem. Even at 45 seconds, our babies were getting cold at 5 minutes. So it's a very dramatic response, and it's a problem for us. And I've talked to other people when I've given talks. Every operating room across the world is cold. So if someone has figured out a way to convince people to make them warmer, I know some of our chairs are obstetricians of this meeting. I would love to do that, because if we could make the operating rooms warmer, we would not have this problem. But apparently we can't. We can't fix this. So yes, the Life Start is a problem, as many devices are, and you saw from the trials that were presented that we need to use at least a chemical mattress. And if you have questions, I can send you the brands, or if you can email me what we use in the United States for that.
Thank you. And then we have a question. I think this is what you also mentioned, Ola. There's a question about how to select babies who need resuscitation. Do you think we need a precise definition of a newborn to be resuscitated? It's Simon Pratesi who asking, and I would add right away that I think ILCOR has quite a good criteria for babies who need resuscitation. But do you have any comments?
Yeah, Simone, and nice to hear from you too. I hope I presented your trial well. For the preterm babies, I think that's a different scenario. I think your question's about the term near term, but just to answer the preterm babies, for the most part, I don't think a lot of them need to be resuscitated. I actually don't think there's a lot of asphyxia in extremely preterm babies. So the reason they're not breathing is they just need some time. And so that's a different group. For the term baby, it's really tone. In the MINV trial, we had color and breathing, but again, going to those, that was mostly in conjunction with our obstetrician that wanted to have clear-cut reasons. The baby has poor tone that's term, they need to be resuscitated. Now, they may not just be, and Ola's shown this too, like if you stimulate them, that might be part of resuscitation during delayed cord clamping, and they may not need anything. But if they're not responding to stimulation, then I would include those babies either with intact cord or milking or something where you could provide assistance. But the biggest marker in these babies, and I think Judith Mersch has shown this as well, is if they're hypovolemic, they tend to be more floppy and less responsive. Hope that helps.
Yeah. And now we have two questions regarding oxygenation. The first is from Gemma Ginevart. In clinical practice, when ventilating with intact cord, a preterm infant, do you recommend FiO2 100?
I could never recommend that with Ola Sogstad on this call. So no, I would not recommend that either yet, because there's no evidence that that works, right? Well, that's why we're studying it, to see if it even, not only whether it works, but whether it's safe. And I think that's why we have to do it in a trial with a DSMB, like with Ola and Max on it, to really say, is this okay, before you even recommend that. And so the answer is no, I don't.
But I think also the question should be, or the answer is, which degree of prematurity are we talking about?
Good point too.
Because those less than 28 weeks obviously need more than those between 31 and 28 and 31 weeks.
Correct.
And then another about oxygenation. What's the hemodynamic or physiologic reason for response to 100% oxygen versus 30% with ventilation when delayed cord clamping is done?
Right. So I may have gone too fast in my talk, but the rationale for 100 was because we were trying to increase the amount of oxygenation for these babies to sort of improve spontaneous breathing, lung aeration, etc. We actually looked at even intermediate ones like 60, and we didn't see this sort of response in terms of improvement when we first tried to pilot this. 30 we picked because now we know that air is not enough. Again, Ola and others have looked at this question, and I think most units, even in Europe, there's very few that I know of in the United States or North America that are using air for preterm babies, despite some recommendations still have 21 to 30. I think nobody's using 21 for extremely preterm babies.
For babies less than 28 weeks, yes. Yeah. And then we have a question about...
Yeah, so just really quick, I know we're running out of time. Abruption, we allow babies that have quote abruption to receive delayed cord clamping, because most abruption is not what we think of, where the placenta is completely detached and the mom, is hemorrhaging everywhere. There are a lot of deliveries where there's a little bit of bleeding, and our obstetricians are more than comfortable doing this. If there is complete abruption or there's a uterine rupture, of course, but those babies, and even antenatally, you'll know those are crash deliveries where things are not going well. So I avoid using the term abruption to exclude babies. I think they can receive delayed cord clamping. We've included them in our trials. So just that's my caveat with that term. That you should still try to attempt it, but if there is a complete abruption to detachment, you'll know that nobody's going to be delaying those babies.
And then there's a question about the level, where you put the level.
Oh yeah,
the baby is contained in relation to the placenta.
Yes, and I think Nestor Vane put the chat on here. Everybody knows his trial that looked at vaginal delivery. There's no difference. I do think at section though, you should try to keep the baby as low as you can, because you don't have that uterus that's completely intact, and so that you need that benefit of keeping the baby at least at the level lower for gravity purposes. This is the challenge with the trolleys, I'll tell you, but we do our best when we can.
Yeah, I always answer that the level doesn't matter. I don't know if that's correct or not, but based on Nestor Vane's trial,
showed clearly no difference at vaginal birth, which is what most of our babies get, and they can go skin to skin, which is nice for the families. I do think at section, I hate when my OBs hold the baby up high to show the mother, because I worry there's some drainage happening by holding them in the air. So you should keep them low if you can.
Yeah. And then we have a question about twin pregnancies. What would be the best option for delayed ligation or milking?
The delayed still is ideal. Now, there's been a few small randomized controlled trials, not many. The one out of Thailand was probably the best one. But even in the US and others, I think in Poland, they've looked at large cohorts of di-di and even dimo twins, because remember, the incidence of IVH is higher in those babies, that it's still doable. You're not seeing acute twin to twin, which many people worry about. We don't do it though if there is active twin to twin, right? Because you now have a baby who has hydrops or concern. But we do it in dimos when we can, and and I'm hoping to publish more data from the pre-mod trial and our other studies to show that this is likely to be safe. I still think immediate cord clamping is the worst thing to do for these infants.
Then we have some questions. One is about skin-to-skin contact. The question from Rachel is not the best way of maintaining temperature. I guess so. It's
Yeah,
important.
no, absolutely for vaginal deliveries, and if you can do it on section that where it's safe. But again, you're not going to do intact cord resuscitation all the way on the mother's chest while they're there. You would need some sort of spacing to do that. So that's why it's a little bit hard. You need
Yeah. And there's a comment here from Singapore where they have
great.
up their operation theaters to 25 degrees for C-section, which is good.
Okay, we'll have to learn from all of you.
So they're probably very positive obstetricians. Yeah, there's another question about performing RCP with an intact cord. We must give 100% oxygen.
And no, I hope people don't think that that's my recommendation. I was trying to be clear. We're studying this.
Yeah.
Okay.
So, and then we have twins again, and I think we have answered that.
Okay.
And there's some Nestor Wayne who likes the presentation. Thank you, Nestor. I think that's all.
Okay.
I think we have commented all comments and questions. So then I think we are at the end of this session. And again, I will thank you, Anup, for this very excellent presentation. And you should all be aware that this is very early in the morning. It's in the night of Anup. So we appreciate very much that you're here. And thank you for all the questions and for all for the audience and Ola. And tomorrow we meet again, and then it's Ola Andersson who will talk about stabilization and resuscitation with intact cord circulation. So see you then tomorrow.
Yeah.
Thank you.
Thank you. Thanks, Ola.
Thank you.